In this video, we're filming a mock interview with one of the heads of departments from a local hospital and a resident applying for physician's training.
Thank you for coming to the interview today. As you know, we're interviewing for the basic physician trainee positions at our hospital. I'll be asking you some questions and then you'll have an opportunity to ask me some questions. Can you tell us why you've applied to come to this hospital?
The reason I'd like to return here for physician's training, there's a few reasons actually. First is that my training here for the last 2 years to date has established that this is a hospital with great culture with regards to respect amongst colleagues, as well as just a very, very high standard of care for medical patients and practicing medicine, which I'd like to just get more exposure to so that I adopt more of those practices within myself. Specifically, this hospital also allows me to get exposure to a subspecialty of interest to myself, which is allogeneic stem cell transplants in the haematology department, and that experience and that exposure can only bode well for me in my career as an aspiring haematologist long term. I also appreciate the social aspects of this hospital, the fact that everyone's comfortable after work to go and grab food together after a long day of work, usually on a Friday. I really appreciate that opportunity to kind of debrief with people that understand what it's like to work at this hospital and the specific triumphs, but also specific struggles that are presented here.
Okay, wasn't bad, but you could have said things slightly differently. You could have said that you enjoyed working at the hospital, so because you've been here for the last 2 years, you thought it was a centre of excellence. Talking about the stem cell allogenic transplant, I don't think is that relevant because you're applying for a BPT job, you're not applying for an advanced trainee job. And even if you get through your physician's exam, it doesn't mean you're automatically going to get offered a haematology advanced trainee job. So it might be relevant to what your long career terms are, but not necessarily why you're coming back to this hospital, because it's unlikely you'd be doing that as a BPT. And you could have mentioned that the hospital's got a good reputation for its pass rate and it's got a very good training program that you feel would suit you. Outline your current training, your strengths and your weaknesses.
In terms of my current training to date, I've done 2 years of internship and residency, which have predominantly been in medical specialty terms, which have granted me great exposure to working with medical registrars and learning from them, as well as medical consultants, and being able to learn specific medical knowledge pursuant to their specialties, but also how to be a consultant and what a physician is, and those are things that I've learnt from them. And then my other experience to date involves being on quality assurance committees at hospital, which allows me to have an understanding of how hospitals work at a governance level and at a systems level. Specifically on the medication safety committee, I was able to be part of a root cause analysis and fix a problem with DVT prophylaxis prescribing. The other experience that I've got is that I've completed a Masters of Philosophy in haematology with regards to AML research, and that has been able to give me good knowledge about how to conduct research and how to recruit patients. In terms of my strengths, I believe that I think I've got a very quality-focused approach to medicine. I've developed a specific template for ward rounding that prompts me to check medication changes regularly and specific specialty related things such as antibiotic prescribing on chemotherapy wards and bowel chart and urine culture results on geriatric wards, and I think that is support for the focus that I have on making sure that medical care that I provide is quality focused and has a high standard. I think another strength of mine is the ability to empathise with people of different cultures. I've worked in a previous job for a year in Japan teaching English, and I've also lived in New Caledonia for a large amount of time, and it allows me to appreciate cultural differences that do prop up, specifically with communicating with people that aren't necessarily of English as a first language. And I think that's a strength that has come through with certain demographics that frequent this hospital, that I'm able to appreciate a bit more that things need to be fleshed out in a specific way with patients. In terms of my weaknesses, I think, some would call it a weakness in that I've got certain commitments outside of medicine. I've got a family to take care of, and I'm heavily involved in a social cricket club that lead to some, a certain sense of juggling. But I think this has also helped in general with good time management. Person with good time management skills, and I think it actually does pose a strength, which I think proves itself in my ability to relate to patients who, do have family values as a very core value, and just on a practical level enable me to talk about social sport with certain patients that enjoy doing so.
That was a pretty good answer. I probably would, even though the interviewer is going to have access to your CV, I probably would have spelled out the individual medical terms, because it may still influence them as to, and also if you've worked outside of the main hospital doing secondments, it'll be worth mentioning them as well. Mm-hmm. Under strengths, you mentioned time management at the end when you talked about weaknesses, but you probably could have brought it in earlier, because what you're telling me about how you do medications and other those things is really time management approach. You could have mentioned maybe you're eager to learn, you've got a strong research interest, and also you know your limitations, you know when to call for help if things aren't going as they should be. Okay, under the weaknesses comment, you talked about juggling your workload with social activities. I would have stressed it more as developing a balance between the two, and that you've been able to prioritise and not let either suffer. Tell us about your approach to physician exam preparation.
Obviously, it's an exam that requires a long-term plan as a build-up to acquiring all of the knowledge that is required, as well as the specific exam techniques. I've already put together a spreadsheet of a schedule of weeks and kind of the recommended topics that are needing to be studied on those given weeks. I've already looked at all the study course supplements, so the immunology course, the statistics and genetics courses, and aligned a calendar that allows me to go to the ones that I think would fit my weak spots. And I've got a burgeoning study group that I've already organised with the other residents in the hospital, because I know from various talks and certain papers that a study group is the most effective way to manage such a large exam. I think one of the other things that I've sought out advice for is how to manage exam stress as the year goes on, kind of dealing with a busy job alongside having to study after that. And I've been able to pull a few resources that the hospital itself has already recommended with regards to meditation courses and time management courses.
Okay, so that was a good answer, but maybe you could have just said, like, the exam's going to be 12 months away or 14 months away. I'm already doing 1 or 2 hours of preparation a night. I'm practicing multiple choice questions. Talking about the study group is good. Maybe you could say how often you're meeting, and what checks you do in the study group as well. Some of the, you can say, I don't know, presumably there's one main course that you're going to do, isn't there? Yeah. Which one was that? Is that the RPA or the Delta Med? Because I don't know, telling me about immunology, all those little courses, not necessarily. But other than that, and the other thing it'd be worth talking about possibly is also saying that there's two parts of the exam. There's the written exam and the clinical exam, and mention that that you're doing some work towards the clinical, but you'll be concentrating on that mainly after the written exam. You're called to an aggressive patient who's punched a staff member. What are you going to do?
So my first step is to try to ascertain the facts of the situation and make sure that there is no further danger as a threat to either staff members or the patient from now on. In terms of managing the threat of danger, I would make sure that vulnerable staff are clear of the area and that the patient themselves is safe, and that means that there's nothing around that they could harm themselves with or harm others with. And then in terms of ascertaining the facts of the situation, I'd probably, if there was credible threat of further harm, I'd engage security to come and provide a safe environment, and then find out from the patient what they're feeling, what has happened from their point of view, and the reasoning behind that, assuming that I'm in a safe position to do so. And then I think management is kind of immediate and flowing on from that. If there is immediate further threat, then a credible threat of harm to the patient itself or to others caused by the patient, I think it would be appropriate to manage that pharmacologically with sedatives. But the more important thing, I think, is the reasoning behind why this patient is the way they are, whether or not there's an acute medical problem that's made the patient this way, some kind of cerebral insult, metabolic insult or otherwise. My approach to common things, if this is an elderly patient, are looking at what drugs the patients are on, whether or not there's anything new, things that are simple like whether or not there's any problems with their bowels, bladder, new infections, and metabolic derangements, and ruling those out with things like simple blood tests and questions and checking the charts, and removing anything like that, and also supportive stuff that can help reorient patients, such as getting the family involved or contacted, getting some reorientation in the patient's room, such as calendars and clocks.
Okay, well, obviously the first question is the patient still aggressive? And if they are, you need to call a code black. It's highly likely the patient's got delirium, so you'd be looking at addressing the cause of delirium and seeing what needs to be done. You need to be talking to the family and the consultant involved in that care of that patient and discussing them what the next treatment is. I mean, is the patient in a secure ward? Do they need to be transferred to a secure ward or to a psychiatric unit? But the main points would be code black, delirium, notifying the family and consultant, and protecting the staff and patients. You have a resident who's underperforming, turning up late and not getting the work done. How are you going to deal with this situation?
I think there's two main issues that I need to address in this situation. One is how to manage the workload of the day, given that I need more resources than I currently have. And two is ascertaining the causes and addressing the causes of the residents underperforming and trying to optimise their performance from then on. In terms of the first issue, I think it involves asking for help early, and what that means is if it's obvious that I'm not going to get through all the work during the day, it's maybe talking to the medical workforce management about whether or not we can pull extra staff, and probably looking at my list early on in the day, making sure that I'm prioritising appropriately the sickest patients that need to be seen if there's a lot of work to be done, and also maybe delegating less of that if I'm not sure about how reliable the resident can be, and probably notifying my consultant early as well about the issues that I might be coming up against. In terms of making sure that the resident themselves, I think it's obviously not ideal for me, but I think it's trying to get to the root causes of the residents' struggle, and whether or not that's a personal issue that's kind of interrupted an otherwise, good and functional resident, and whether or not stuff's come up. So I think first protocol would be approaching them about it, talking to them in explicit terms about what's going on and whether or not there's anything that they want to tell you or you can help with. And then after that, if it's something that you can offer resources for with regards to specific problems, if it's specifically about consults, or if it's specifically about how they're going to organise their day, provide that education specifically, or find a resource for them to get that. If they're struggling for a personal reason and they're not willing to engage with me on it, I think it's probably something that I would have to talk to a superior about and how far to go with, and making sure that they're okay in terms of their supports, and seeing if there's anything I can do to point them in the direction of a support service like employed assistance and those kinds of things. And eventually, if it were just a continual issue, I'd probably end up talking to the director of pre-vocational training about their skill set.
So it wasn't a bad answer. I had a problem with you asking for help early on. I mean, realistically, there's not going to be any help. So the critical things are, why is the person turning up late? You need to have a discussion with them. Is it a personal matter? Is it just because they've slept in? Or are there other factors? And then, is it a workload issue? If it's a workload issue, maybe you could get the work done by prioritising things for the person to do, work out what they're having difficulty with, and see if you can get around that. And then you have to prioritise and do what you can do yourself. It's not going to be any different than him being on an ADO or something. So you shouldn't have to ask for help. If it's an ongoing problem, I mean, it might be one-off, but if it's an ongoing problem, clearly it has to be discussed with the consultant, and then the consultant's going to have to escalate it further. It's not necessarily your responsibility to go above the consultant to take it to the Director of Physician or Educational Training or whatever. You find that the ward rounds are taking too long, you haven't had time to see the new patients, and you haven't had time to see consults. What will your approach be?
So I think initially I'd have to sit down after a day of this issue and try and knuckle down on, I guess, the individual problems, whether or not it's that currently we've got a very, very, very long list that you would expect to have a long ward round, or whether or not it's that we're being inefficient in doing the ward round. And then I'd probably, if it was that case, I'd probably have to zero in on what occupies most of the time on the ward round, whether or not it's an issue of us trying to do jobs that are of a lower priority during the ward round that can be deferred till later, and whether or not it's just an issue with taking too long doing unnecessary things, and just being too shy to kind of say the reasonable thing of we've got to move on during the ward round. I think if this is a persistent workload problem, that's come up more than once, I'd probably talk to the consultant about strategies to manage workload, and whether or not they've got anything to help with. And if it's the consultant ward rounds themselves, I suppose, I would specifically need to explicitly bring it up with them. Maybe it's me not having made them aware of how much work outside of their ward round that there is to do, or whether or not it's just something that they're for whatever other reason haven't thought about, and I could just bring it up and have a simple fix that way.
I guess the question is, some of the strategies could have been to try and see the new patients first,
yes,
to get them sorted. And if it is a long ward round, which is not uncommon in geriatrics, well then maybe you need to see whether the junior doctor can go off and do some other jobs while you're doing the ward round, and just have a debrief regularly through it. Yep. And discuss with the consultant. Discuss with the consultant the issues and see if there are any strategies that you could develop together to try and minimise staying back late. You disagree with your consultant over the management of a particular patient. How are you going to deal with that?
I think in the first instance, if a consultant has given me a plan that I find jarring, I think it's to clarify the specifics of the plan and the rationale behind the plan. In the first instance, if I'm just missing something and it's a matter of my knowledge, then I think that's the first thing to address. If after clarification I still find that I disagree with the plan for a particular patient's management, I think it's important for me to hash out my specific reasons as to why, and whether or not there's anything that maybe I know that the consultant doesn't know, and maybe have a second discussion, making sure that we've both got all the information at hand. And if it's still an issue where I disagree after we have clearly both got access to the same information, I think obviously I should have a discussion with the consultant. We've already been having a discussion, getting the information back and forth, but fleshing out my specific particular concerns, and seeing within myself whether or not they come from just a subjective preference that I've got, or some kind of specific hospital cultural habit. If it comes down to it, obviously the consultant has the legal care of the patient and determines the care of the patient. But if it's something that is obviously some kind of issue that I think would lead to obvious and inarguable harm to the patient, I think at that point I'd have to talk to someone else, and tell the consultant that was what I was doing. And I think that would probably, my first port of call would be the physician, the director of the physician training at that hospital, just to get some guidance as to what to do next.
Okay, so that wasn't a bad answer. If you disagree about a particular treatment, obviously one of the questions is, have you got your facts wrong? So you need to look up some research and see who's correct and who isn't. If you you still need to make your reservations known to the consultant and see if he can overcome them for you. And if after looking at the literature you still can't come up with a possible solution, well then you probably would have to tell the consultant, look, you're not comfortable with this treatment. Is it okay to discuss it? I'd probably go to the head of department first, yes, rather than, or ask for a second opinion, but the consultant may not want to do that. And what are your long-term career goals?
Long-term, I intend to become a staff specialist haematologist, and I'd like to be in a staff specialist position at a tertiary hospital for the specific reason that I'd like to pursue work with allogeneic stem cell transplants. This specific type of medicine requires you to be placed at a tertiary centre, just because of the referral catchment that's required to be able to perform these at a high volume and develop expertise within them, as well as be involved in the research around them, which requires that same patient set to be accessible to you as a practitioner of health. In a more personal sense, I'd like to retain the sense of empathy that I have for patients at that stage of my career, and not get too bogged down in managing a department or anything like that, and being still able to connect with patients and ascertain their priorities and wishes so that I can affect them for those patients. On a governance level, I'd like to be involved in a medication safety position. I've been involved in certain committees to date, and I think that's the most effective way to improve patient care. Something like 1 in 5 hospital admissions are due to medication-related errors, and that's something that I feel passionate about and would like to leverage kind of a consultant position with regards to making improve in a health system. And the last thing is that at long term, I'd like to be able to also retain a sense of work-life balance, and be able to continue to pursue the things that are important to me outside of medicine, mainly being present for my family and long-term involvement in the cricket club.
Okay, so there's a couple of things that sort of wasn't that good in the answer. I mean, you're stressing the stem cell allogenic transplant. I mean, that can only come after you become a haematologist. What happens if they haven't got a job in that field? What, you can't do any work? I mean, so you're putting everything, it sounds like the only reason you want to do haematology is to do stem cell transplant. That's only a small part of haematology. And saying you don't want to do, you're going to be bogged down doing head of department work, so you're not going to be a head of department. Doesn't sound too aspiring. Yeah. I probably would have said something like, I'd like to get my physician's exam, get a PhD, develop an international reputation in research, and use that experience, and perhaps work overseas, and then use that experience to come back and work in a tertiary hospital with a special interest in stem cell allogenic transplants. But if that wasn't available, I would still be working in haematology. Yeah. And then you could add the other bits in, so that's obviously medicine's not going to be your whole career, so you want to have enough time to do other things. Yeah. But and the bit about quality medication management committee, I mean, you can say you've been impressed by, well, you've enjoyed your work in quality assurance type projects, and that would be something you'd like to continue with, to try and improve the safety of care within the hospital. You don't necessarily have to specify that you're going to be on a medication safety management committee, because then how's that going to, just being on a committee doesn't do anything. What are you actually going to do to improve medication safety?